Hello, my name is Dr. Sunil Gupta and this is a podcast on a BMJ article, COVID-19, a remote assessment in primary care, written by Tricia Greenhall, Gerald Chun-Ha Ko and Joseph Carr. It was published on the 25th of March 2020. First, a disclaimer. This podcast is based on the BMJ article on COVID-19, a remote assessment in primary care. It is written to help spread invaluable advice at a time when helpful information is urgently and desperately needed. You are strongly advised to seek advice from your national professional organisation and the World Health Organization for the latest evidence-based advice. So the summary of this article is most patients with COVID-19 can be managed remotely with advice on symptomatic management and self-isolation. Although such consultations can be done by telephone in many cases, video provides additional visual cues and therapeutic presence. Breathlessness is a concerning symptom, though there is currently no validated tool for assessing it remotely. Safety netting advice is crucial because some patients deteriorate in week 2, most commonly with pneumonia. And there's a very helpful infographic, and this PowerPoint will also go through this infographic as well. 1.0 COVID-19 remote assessment in primary care. Novel coronavirus 2019 COVID-19 is an urgent and spreading threat whose clinical and epidemiological characteristics are still being documented. With a view to containing COVID-19, a shift from in-person to remote consulting is occurring. Clinicians are thus faced with a new disease and a new way of interacting with patients. This article will present some guiding principles on how to choose between telephone and video appointments, how to conduct a query COVID consultation remotely, and considerations when arranging follow-up and next steps. It does not cover remote triage or how to set up video consulting in your practice. This article is intended as a broad orientation to a COVID-19 consultation. It does not cover every clinical eventuality and should not be used as an official guideline for the management of a COVID-19 patient. National and local guidelines are being urgently produced, and further research has been undertaken on specific aspects of management, such as use of antibiotics. 2.0 Telephone or video. The telephone is a familiar and dependable technology which is adequate for many COVID-19 related conversations. Patients who just want general information about COVID-19 should be directed to a telephone message or online symptom checker such as NHS 111 online, whose web address is 111.nhs.uk/COVID-19, or other online resources. Those with mild and uncomplicated symptoms and those consulting for administrative reasons can generally be managed by telephone. In the UK, sickness certificates can be downloaded directly from NHS 111 online. However, video can provide additional visual information, diagnostic clues, and therapeutic presence. Hence, video may be appropriate for sicker patients, those with comorbidities, those whose social circumstances have a bearing on the illness, and those who are very anxious. Patients who are hard of hearing may prefer video to telephone. Note that many countries, including the United States, are formally relaxing privacy and data protection regulations for video and other communications technologies during the crisis. The GDPR, the General Data Protection Regulations which apply in the United Kingdom and the European Union, already include a clause exempting work in the overwhelming public interest. 3.0 Before you connect. Open the patient's medical record, preferably on a second screen if using video. Check for risk factors for poor outcome in COVID-19, including immunocompromised states such as frailty, diabetes, chronic kidney or liver disease, pregnancy or taking chemotherapy, steroids or other immunosuppressants. Also check for risk factors like smoking, cardiovascular disease, asthma or chronic obstructive pulmonary disease. Enter a code for a video or telephone consultation, and perhaps also write in the records that this consultation was in the context of the COVID-19 pandemic, and have your current stay-at-home COVID-19 guidance on hand. 4.0 Establishing a technical connection for a video consultation. Research shows that if the technical connection is high quality, clinicians and patients tend to communicate by video in much the same way as an in-person consultation. When you're ready to connect, follow your local procedure. In some cases, for example, the link may be via a fixed URL, and in others, a new URL will be generated for each appointment. When connected, check video and audio. Can you hear me? Can you see me? And ask the patient to do the same. If necessary, prompt the patient to unmute and adjust their microphone. You may need to call them on an ordinary telephone to troubleshoot this. Make sure you have a record of their phone number in case you need to call them. 5.0 Beginning the consultation. Check the patient's identity. For example, if they are not known to you, ask them to confirm their name and date of birth. Speak to the patient if possible rather than their carer or family member. Ask where they are right now. Most patients will be at home, but they may be staying somewhere else. Then begin with a ballpark assessment, i.e. very sick or not so sick. What are they currently doing, i.e. lying in bed or up and about? Do they seem distressed? Are they too breathless to talk? If you are using video, do they look sick? If the patient seems sick, go straight to key clinical questions as appropriate. Otherwise, take time to establish why the patient has chosen to consult now. For example, are they or a family member very anxious, or are they concerned about a comorbidity? Find out what the patient wants out of the consultation, for example, clinical assessment, certification, referral, advice on self-isolation, reassurance. 6.0 Taking a history. Note the approximate incidence of key symptoms and signs listed in the infographic right-hand column, with the caveat that this list was generated in a different population and may not reflect your own case mix. The infographic guidance should be used flexibly to take account of the patient's medical history and issues that emerge during the conversation. More serious cases typically develop worsening respiratory symptoms, which may indicate pneumonia. Elderly and immunocompromised patients may present atypically. Note the date of first symptom to date stamp the onset of disease. Many but not all patients will have a thermometer at home. Ask how high their temperature is currently, how long the fever has lasted, and what the highest reading so far has been. The fever in COVID-19 is often but not always greater than 38 degrees and tends to persist beyond 5 days. Note that up to half of all patients with COVID-19 have no fever at initial presentation. Most but not all patients with COVID-19 have a cough. It is usually dry, though a substantial proportion of patients have sputum production and typically persists for more than 5 days. Fewer than half of patients with COVID-19 have shortness of breath or difficulty in breathing, but if they do, this tends to indicate more serious disease, especially pneumonia. It is therefore important to assess respiratory symptoms carefully, though the evidence based on how to do this is weak and expert opinion divided. If the patient has asthma, ask how many puffs of their reliever they are currently taking per day and whether this has increased recently. Systemic symptoms include fatigue and muscle pain, though many patients have neither. Ask about a history of contact with a case of COVID-19, either laboratory confirmed or clinically suspected, especially one who had been closer than 1 metre or 30 minutes for 30 minutes or more. The incubation period for COVID-19 is 2 to 14 days and on average 5 to 6 days. Ask if anyone else in the immediate family is unwell. Other risk groups include healthcare workers, others working in a healthcare environment such as cleaners, and transport workers. Travel to a known hotspot is less relevant as the virus is now widespread. Type World Health Organization situation report into Google for the latest worldwide incidence. Features that generally indicate a condition other than COVID-19 include nasal congestion, which is present in only 5% of cases with COVID-19, conjunctival congestion, which is only present in 1% of cases of COVID-19, and other allergic symptoms such as itchy eyes. A preliminary report suggests that although conjunctival involvement is rare in COVID-19, it's a poor prognostic sign if present. Distinguishing seasonal influenza from COVID-19 can be difficult, but as a rule of thumb, seasonal influenza is more likely to produce body aches, and COVID-19 is more likely to produce shortness of breath. Gastrointestinal symptoms such as diarrhea were initially said to be rare in COVID-19, but there is emerging evidence that they may be commoner than previously thought. Loss of appetite occurs in many patients, and there are widespread anecdotal reports that anosmia, a loss of sense of smell, is a common and early symptom. 7.0 Red flags. Red flag symptoms which indicate that the patient needs urgent assessment either in person or by a good video link, depending on the clinical circumstances, include severe breathlessness or difficulty breathing, pain or pressure in the chest, blue lips or face, stories suggestive of shock such as cold and clammy with mottled skin, new confusion, being difficult to rouse, significantly reduced urine output, hemoptysis, neck stiffness, non-blanching rash. 8.0 Remote assessment of breathlessness. There are no validated tests for the remote assessment of breathlessness in an acute primary care setting. A rapid survey of 50 clinicians who regularly assess patients by telephone revealed some differences of opinion. For example, most but not all rejected the Roth score, which times how long it takes for a patient to take a breath while speaking, on the grounds that it's not been validated in the acute setting and could be misleading. However, there was consensus among respondents around the following advice. 1. Ask the patient to describe the problem with their breathing in their own words and assess the ease and comfort of their speech. Ask open-ended questions and listen to whether the patient can complete their sentences. How is your breathing today? 2. Align with the NHS 111 symptoms checker, which asks 3 questions developed through user testing but not evaluated in formal research. Are you so breathless that you are unable to speak more than a few words? Are you breathing harder or faster than usual when doing nothing at all? Are you so ill that you've stopped doing all your usual daily activities? 3. Focus on change. A clear story of deterioration is more important than whether the patient currently feels short of breath. Ask questions such as, is your breathing faster, slower, or the same as normal? What could you do yesterday that you can't do today? What makes you breathless now that didn't make you breathless yesterday? 4. Interpret the breathlessness in the context of the wider history and physical signs. For example, a new audible wheeze and a verbal report of blueness of the lips in a breathless patient are concerning. There is no evidence that attempts to measure a patient's respiratory rate over the phone will give an accurate reading, and experts do not use much such tests. It is possible, however, to measure the respiratory rate via a good video connection. More generally, video may allow a more detailed assessment and prevent the need for an in-person visit. Remote physical examination. A physical examination will be almost impossible by phone and difficult by video, so you will have to make compromises. In a video consultation, assess the patient's demeanour, whether they're lying in bed or up and about, skin features such as flushing, pallor, cyanosis, though note that if lighting is suboptimal, this can be difficult to assess, and oropharynx. Congestion of the throat and tonsillar swelling are both rare, present in about 2% of COVID-19 cases. When making records, note what you can and cannot see. You may or may not get a view of the patient's throat, for example. Assess respiratory function as best as you can. It may be possible to get the patient to take readings from instruments they have at home, for example, temperature, pulse, blood pressure, blood glucose, peak expiratory flow rate, and oxygen saturation. If you are using video, you can check whether the patient is using the equipment correctly. They may have purchased it only recently. Bring your own device into camera view to show them how to use it if necessary. Fitbit-type gadgets and smartphone apps can measure biomarkers such as pulse and, on rare occasion, oxygen saturation, but there are many such products and their accuracy can be hard to judge. Really, patients may have a home pulse oximeter. If you record a reading made by a patient with such a device, also note your confidence in its accuracy, especially if it seems out of line with your wider assessment. Assess pre-existing conditions and medications taken. Asthma and cardiovascular disease are particularly relevant, and it's important to ensure that these are well controlled and the patient has adequate medication. Attend to mental health. Does the patient sound or appear upset or distressed? Formal mental health assessment instruments are unlikely to be useful in this setting. Are there relevant family issues which may be within earshot or camera view, such as small children whose care will be affected if the patient becomes more unwell? 10.0 Managing mild or moderately severe disease. Most community-based patients with COVID-19 can be managed by remote advice, see infographic. COVID-19 is a frightening illness, even if the patient only has mild symptoms. Explain that the condition is managed in a similar way to the flu and often takes a similar course, though it can deteriorate. About 4 out of 5 patients will have a relatively mild form of the illness. They should rest and take fluids and symptomatic remedies such as paracetamol. People already taking non-steroidal anti-inflammatory drugs should continue these, but others should avoid remedies such as ibuprofen, as some anecdotal reports have raised concern about its safety in COVID-19. Regular medication, including ACE inhibitors and angiotensin receptor blockers, should be continued. Adjust your advice depending on clinical features, comorbidities and social support. A patient with asthma would need advice to step up treatment if their peak flow drops. Those with COPD may need antibiotics for an infective exacerbation. A social safety net will be important in patients living alone. Explain any arrangements for self-swabbing, which at the time of this podcast is not currently being offered in the UK, but this may change, and any arrangements for dropping of specimens and picking up medication. If the patient has COVID-19 symptoms, remind them to get someone without symptoms and who has not been a close contact to attend the pharmacy on their behalf and leave the medication at the doorstep and not enter the house. All paperwork, including prescriptions and sick certificates, should be sent electronically. If COVID-19 is a presumptive diagnosis, self-isolation should occur for 7 days, but all household members should self-isolate for 14 days from when the index case became ill. If circumstances allow, the person with symptoms should also self-isolate within the home and stay as far as possible from vulnerable family members. All family members should wash their hands regularly with soap and water and follow the stay-at-home guidance for advice on cleaning and disposal of waste. Patients who cannot confidently be classified as having mild illness on the basis of the remote consultation may need to be followed up remotely or seen in person, and should follow your local protocol for home treatment and monitoring. Comorbidities such as asthma or diabetes may need active management, and serious differential diagnoses such as bacterial pneumonia, meningitis or sepsis should be considered. Not all acutely sick patients have COVID-19. 11.0 Safety net advice. COVID-19 can produce rapid deterioration in respiratory function, especially in the second week, so safety netting advice is important for all patients, even if they are currently well. Document that you've done this. Those living alone should identify someone to check in on them regularly. They should maintain a high fluid intake, see infographic, and seek medical help if they deteriorate. In particular, if they have difficulty breathing, feel faint, stop passing urine, or are unable to keep down fluids, they should call their GP or out-of-hours service as appropriate or follow your local protocol. Ask them to write this down or send a patient information leaflet electronically. Patients who are very unwell, and especially those with possible pneumonia, need to be urgently assessed either by video or in person, depending on the clinical circumstances. The clinical criteria for hospital admission in COVID-19 pneumonia are the same as for any other pneumonia, but in the current crisis there may be additional restrictions. The best clinical signs to predict community-acquired pneumonia in an adult are temperature above 38 degrees Celsius, respiratory rate above 20 beats per minute, and a heart rate above 100 beats per minute with new confusion. Low urine output is also a concerning symptom. Anecdotal reports from UK secondary care suggest that hypoxia is often used as the cut-off for admission. Both the World Health Organization and a guide based on the China experience recommended a cut-off level of 93% for classifying pneumonia as severe. Current UK NHS guidance recommends hospital admission if saturation on air is below 94%. Additional features in children include grunting, central cyanosis, and an inability to breastfeed. The authors recommend that, in the case of patients with a very poor prognosis, for example multimorbidity and other risk factors, a ceiling of treatment conversation is considered. If the patient is very sick and death almost inevitable, whether ventilated or not, some people may prefer to stay home and opt for palliative management. Many such patients will already have an advanced care plan and do not attempt cardiopulmonary resuscitation flag, and in those who do not, urgent efforts should be made to put these in place to avert unwanted emergency interventions. 13.0 Notification. COVID-19 is a notifiable disease in the UK. Laboratory confirmed cases should be notified immediately. Current professional consensus is that clinically suspected cases should also be notified. At the time of writing, the situation is changing rapidly. This article will be updated as new evidence emerges. National and local protocols are likely to emerge for the topics covered in this article and other aspects of care in COVID-19. So now come to the infographic. First, the top half. So this graphic, intended for use in a primary care setting, is based on data available in March 2020, much of which is from hospital settings in China. It will be revised as more data emerges. So number one, setup. So prepare yourself and decide how to connect. Have current stay-at-home COVID-19 guidance on hand. Video is useful for severe illness, anxious patients, comorbidities, and those who are hard of hearing. Scan medical record for risk factors such as diabetes, pregnancy, smoking, chronic kidney or liver disease, COPD, steroids or other immunosuppressants, cardiovascular disease, asthma. Number two, connect. Make video link if possible, otherwise call on the phone. Check video and audio. Can you hear me? Can you see me? Confirm the patient's identity, name, date of birth. Check where patient is. Where are you right now? Note patient's phone number in case the connection fails. If possible, ensure the patient has privacy. 3. Get started. Quickly assess whether sick or less sick. Rapid assessment. If they sound or look very sick, such as too breathless to talk, go direct to key clinical questions. Establish what the patient wants out of the consultation, such as clinical assessment, referral, certificate, reassurance, or advice on self-isolation. So the next part of the infographic is on number 4, history. Adapt questions to patient's own medical history. Contacts. So close contact with known COVID-19 case, immediate family member unwell, occupational risk group. History of current illness, date of first symptoms. So the most common presentation is cough. Cough is usually dry, but sputum is not uncommon. Fatigue, fever. Up to 50% of patients do not have fever at presentation, and shortness of breath. Number 5, examination. Assess physical and mental function as best as you can. Over the phone, ask carer or patient to describe state of breathing, colour of face and lips. Over video, look for general demeanour, skin colour. Check respiratory function. Inability to talk in full sentences is common in severe illness. How is your breathing? Is it worse today than yesterday? What does your breathlessness prevent you doing? Patient may be able to take their own measurements if they have instruments at home of things like temperature, pulse, peak flow, blood pressure, oxygen saturation. Interpret self-monitoring results with caution and in the context of your wider assessment. So the clinical characteristics based on over 1,000 hospitalised patients in China, 69% have cough, 22% have a temperature between 37.5 and 38 degrees Celsius, 22% have a temperature greater than 38 degrees Celsius, 38% have fatigue, 34% have sputum, 19% have shortness of breath, 15% have muscle aches, 14% have sore throat, 14% have headaches, 12% have chills, 5% have nasal congestion, 5% have nausea or vomiting, 4% have diarrhea, and 24% have any comorbidity. And the red flags to look out for COVID-19 are severe shortness of breath at rest, difficulty breathing, pain or pressure in the chest, cold, clammy or pale and mottled skin, new confusion, becoming difficult to rouse, blue lips or face, little or no urine output, coughing up blood, and other red flags to look out for which are not COVID-19 are neck stiffness and a non-blanching rash. So carrying on with the infographic, number 6, decision and action. Advise and arrange follow-up taking account of local capacity. So which pneumonia patients are sent to hospital, clinical concerns such as a temperature greater than 38 degrees Celsius, a respiratory rate greater than 20 per minute, a heart rate greater than 100 per minute with new confusion, and an oxygen saturation less than or equal to 94%. So they could be likely COVID but well with mild symptoms, in which case the answer is self-management, fluids, paracetamol. They could be likely COVID-19 unwell deteriorating, in which case the management is arrange follow-up by video, monitor closely if you suspect pneumonia. If there's relevant comorbidities, do proactive whole patient care, and obviously if they're unwell, need admission, then it's an ambulance protocol 999. So for those likely COVID but well with mild symptoms, those likely COVID-19 unwell deteriorating, and those with relevant comorbidities, you need to reduce the spread of the virus, follow current government stay-at-home advice, and then safety netting. If living alone, someone to check on them, maintain fluid intake 6 to 8 glasses per day, seek immediate medical help for red flag symptoms. So there's some information about how the article was created and the acknowledgements. And there's a set of references on which this article is based. And there's some more references on which this article was based. So in summary, most patients with COVID-19 can be managed remotely with advice on symptomatic management and self-isolation. Although such consultations can be done by telephone in many cases, video provides additional visual cues and therapeutic presence. Breathlessness is a concerning symptom, though there is currently no validated tool for assessing it remotely. Safety netting advice is crucial because some patients deteriorate in week 2, most commonly with pneumonia. And there's a link to the actual BMJ article, which I would strongly suggest that you look at the latest version. Thank you for listening and watching this podcast.